Hello dear friends, today I would like to continue our video reviews about theme of central relation. And today we are going to talk about methods of its determination. As you understand, there are a lot of such methods and it already shows the inconsistency of the different terms of central relation. So, the first method that I use the most is a non-forced, that is without effort, movement of the lower jaw. Very often you use this method in cases with full adentia when working with wax templates and providing registration. The only thing I would surely like to say is that you do not need to hit a wax template. The second, a very common mistake is when registering when we seem to have relaxed muscles to ask the patient what to do. Close his mouth. This is where the mistake is made, because when we ask to close the mouth, it leads to tensing of the masseter muscle, lateral pterygoid muscle, temporal muscle. And in fact, when you close your mouth, if you take any object when biting off, what happens? Lateral pterygoid muscles work because we are trying to grab it with our teeth. That is, you see a piece of meat. Your mouth does not simply open, but the jaw begins to move forward. Therefore, if you ask the patient to close his mouth, at least 4 paired muscles start to work. Just imagine you were relaxing the patient and achieved the immediate reactivation of 4 paired muscles. Therefore, what should we do? We must help relax the muscles as much as possible, distract the patient, and then with your fingers, without pressing on the jaw, you bring it to touch with the register. Whether it is a wax template, whether it is a wax register of the central relation, as shown here on the slides, which were used in this case. What other methods do we have to register the central relation? Protrusion of the tip of the tongue along the palate posteriorly, and the method when we ask the patient to swallow saliva. There are the methods that we use in removable prosthetics. Then, what does the patient do? He tries to move the lower jaw forward. Very often, toothless patients, what do? They hold the jaw forward to hide the lip sickness and create the exposition of the teeth. And when you register, patients move the jaw forward, and it's extremely difficult to cope with. And this is their usual position. It's called geriatric prognatism. And what do? We do kind of certain tricks. Please note, at the back edge of the template of this rigid template, I model a small wax roller and I ask the patient what to do. Throw back his head. My jaw, pay attention, throws back. After I heat up the template in the lower area, I warm up a small layer of aluminum wax. We have a separate course on full removable prosthetics. I think that we will make a topic-oriented video devoted to this issue and I will show everything, but now in short, a few words literally. We warm up the wax and quietly help patient to close the mouth and ask him to fill with his tongue that wax roller. What happens? The patient tongue pulls back the head and muscles pull back the jaw as well. And in the last moment when patient closes the mouth, you ask him to swallow saliva. Actually, when swallowing, the lower jaw supports on dentition, on molars, a little bit distally, and the act of swallowing happens. That's a classical way. Actually, in this case, we get not a centric relation, but somewhat distal position. But on this occasion, it's better to get such a position than a massive prognatism of the lower jaw. There is a bimanual Dawson method. It was built on allegation of this author associated with the assumptions about the anatomical construction of the articular fossa, that is, the condylar process related to the fossa as a hinge. I especially took the slides. I don't want you to think that I'm deceiving from his book. Pay attention. So we can bimanually set the process to the articular fossa. But if we base on anatomy, You can see that position of the process is extremely individual. These slides was taken from Miyashita book, Kunihiko Miyashita. I highly recommended you this book, especially for those who are interested in rentgenology and radiographic anatomy. And pay attention on axis direction. They are absolutely different. So if you do this patient that kind of technique, you will get whatever you want to except the central relation. Managing of closing Paschen Ramford is almost the same but with the help only one hand. That is, Dawson stayed back and provided registration with the support of thumbs on the chin, the other fingers wrapped around the mandibular ramus, and do the cranial movements of the lower jaw with a slight rotation. That is, not distal movements, but the process is set in the anterior-superior position, and then the registration is provided. Again, if you ever have done the dissection of cadaver joint, you could see how simply the jaw might be displaced in the temporomandibular joint manually. One more method is use of a jig. There are many kinds of jigs that are used in dental practice. There are a long-term jig, the Coes appliance, but there are a lot of questions dedicated to that appliance as it is given to a patient for use for 1-2 weeks. And even I watched one video where a doctor directed to use it more than 3 to 4 weeks. Colleagues don't do this. It can lead to numerous complex complications. Jigs are for short-term use, that is for deprogramming. What is the deprogramming of TMJ or muscles or whatever, we'll overview in another video as it requires more deep explanation. Now I have no time to do this, but in any case it can be achieved by a doctor. That is, we place a front deprogrammer and register with the use of silicone the jaw relationship. The laminated calibrator, there are some of its modifications which allow us to do the following. Gradually to remove the stripes, the calibrator is set in the oral cavity, the teeth are closing and the doctor removes the stripes till the occurrence of primary contact in distal area, for example. Then the one stripe is taken back and the registration is provided. All negative moments of the programmers is related to the fact that patients themselves can clutch the teeth and move the jaw in distal position, as these devices are set between the palatal surface of upper incisors and incisive surface of lower incisors, making such a spool. And again, it can be difficult to do with a distal bite. One more technique is bilateral stimulation. Often doctors use it in that way. Cotton rolls are placed in the premolar area, right and left side, and you ask the patient to hold them very slight. So that occurs the muscle relaxing. I often say that I have my own theory about why people do smoke. They put the cigarette between the teeth and then the muscle relaxing occurs. And I heard it at seminars many times and from other doctors themselves who also heard about it. Those lecturers ask to squeeze hard that cotton rolls and they expect the muscles to get tight. Colleagues, night boxers can clutch the teeth during 4 to 5 hours and even more so. If you think that you can give the patient in the dental chair cotton rolls for 4 to 5 hours and he will be relaxing all the time, it is a fundamental misconception. Also, after compression, there is a very high muscle activity and not at all patients it decreases quickly. In some patients, it continues to stay during some hours as well. So please do not clutch anything. Bilateral stimulation comes down to that the patient sit with a half-opened mouth and hold slightly these rolls with the teeth so that you can provide a registration. One more method I would like to discuss is formation of a aortic arch tracing. Wonderful method. I would like to use it almost always. Gnathometer is used there or centrifix as well can be used there, and mostly it is used in patients with full edentia. One of them is placed in the oral cavity and registration is provided. So the patient can draw an arrow forward, back, protrusion, retrusion, and to the right, to the left with the help of natometer, and then you have the point of intersection from which we can build all type of movements. And so that you receive that central relation you wanted to get. But about that we will talk in details once more in the videos about full removal prosthetics, as it is so nuanced we must take it into account before determining their relationship. It is not well suited for the patient with T, so to say. At first video about central relation was demonstrated that we have a diapason within 15 to 20 millimeters where a determination of central relation can be provided, and if you establish a device for tracing a Gothic art to a patient with teeth, the bite height increases and jaw shifts. I'll be glad if you have any questions. Please write down. I'll answer it with a great pleasure, and for the best we'll create a video answer. Like it, comment, subscribe to our channel, and welcome to our courses. We'll be glad to see you live there. Thank you very much. See you.